Hey guys, do you hear me well, Dr. Waleed and audience?
Yes, we can see you well.
Excellent.
Okay, we're going live now. We'll give him 1 minute and then okay. Assalamu alaikum jami'an. Welcome and thank you for joining us in this amazing webinar that is hosted by SASIS in collaboration with Sky. And you can see with the agenda, we're going to start with a great speaker that we had the pleasure to have. Dr. Tai Kobayashi is an interventional cardiologist at the Hospital of University of Pennsylvania. He currently practices in advanced coronary intervention, including CTO and device-assisted high-risk PCI and TAVR. He's best known for his innovation and expertise in the emerging fields of advanced pulmonary embolism interventions, including also renal denervation technologies, and he considered a key opinion leader in these fields. He currently serves as Director of Interventional Cardiovascular Service at the VA hospital in Philadelphia. So let's welcome Dr. Kobayashi, and we'll start with his talk.
Thanks, everybody. Thank you so much for being here. I recognize that it's late on your guys' side, so I appreciate everybody being here. I've been given the talk here to cover the guidelines of what we have out there. And so I'm going to try and break this a little bit brief because I think everybody here knows the guidelines here. And we'll talk a little bit about what it looks like in North America. We'll talk a little bit about the European guidelines. And then, of course, we'll talk about what's happening at home for you guys. So we'll start with the prevalence of hypertension in Saudi Arabia. You guys can see here that I've kind of highlighted the various different rates of hypertension that's being seen in Saudi Arabia. The most recent updated report from Household Health Survey carried out by the General Authority of Statistics shows that there's about a 9.2% chance of patients having hypertension in Saudi Arabia. I think this is probably underestimated. But with this current estimate, there's about 1.3 million Saudis. You could see that in various different regions of Saudi Arabia, hypertension affects a different proportion of patients. But as you start to get older and older, as we're everywhere else in the world, hypertension increases to affecting about half of the women and 48% in men and citizens over 65 years old. So this is a global problem. It's not to say that we all have the same issues with hypertension. So I'm hoping this is already something that you guys have already been experiencing in the office, and this is what we're going to be talking about today. So as you guys may have known in the European Society of Cardiology guidelines from 2024, in speaking about how hypertension has been treated, the addition of renal denervation, I just wanted to kind of show you at the very, very bottom here. Originally it was looking at what were some of the reasons to go forward with renal denervation. You could see that in 2024, renal denervation is not recommended for treatment of patients with moderate to severely impaired renal function, but it is, a 2B indication to be considered for patients with both increased cardiovascular risk and uncontrolled hypertension on fewer than 3 drugs. And so that's that second category of a 2B level of evidence A. But you really want to limit this for eGFRs less than 40 because they haven't really been included into studies that Debbie will kind of go into in a second. So I'm sure you guys have all been seeing, but that was the European guidelines. We don't really have a lot of direction on the North American side, and Sky has really been leading the way here in North America. Hence the reason why we've been reaching out here, and I'm glad that Sky had the opportunity to have a joint program with you guys. But this is the most recent position statement on renal denervation for hypertension in North America. We talked a little bit about patient selection, operator competence, training techniques, and organizational recommendations. Of course, these are just recommendations. They're not regulations or requirements by any means. But nonetheless, it mirrors what we have with our European colleagues, which is to say that we get referrals from primary care or a specialist provider, which Dr. Cohen will talk to you a little bit more about. We'll talk about ruling out secondary causes of hypertension, which I think is really, really important, which I kind of see that there are some cases that we're going to be following here, just to make sure that you guys understand that renal denervation is not the only treatment for hypertension. But really, the idea here is to make sure that you confirm that this is truly essential hypertension, that you do all of the secondary hypertension workup, you discuss the risks and benefits of thinking about more advanced therapies for hypertension. You make sure that, again, there's no bilateral renal artery stenosis. And then finally, if the patient has not achieved control, renal denervation could be considered as an option for the overall inclusion of treatment into the treatment plan. And similarly, there are guidelines that have come out in Saudi Arabia. This is from 2023 in the management of hypertension from the Saudi Heart Association. Just to remind you guys, how this is separated out in regards to the class of recommendation. It's a very easy color-coded system: green, yellow, orange, and red. And then this is what has been reported in the Saudi Arabian guidelines here. So based off of the data that was previously published, renal sympathetic denervation may be considered in people with treatment resistant, as defined in Table 12, which we'll talk about in a second, and also in people with uncontrolled hypertension, high cardiovascular risk. So this really kind of mirrors what the European guidelines would suggest. It's a lot more strongly worded and more defined than those that, there really is nothing in North America as of yet. And we'll talk a little bit about what's coming down the pipeline. But nonetheless, these are, again, just pulled straight out of the Saudi Arabian guidelines here. Resistant hypertension defined, as 3 or more antihypertensive medications. But really, when you should really consider this as an orange, to say you can consider the use of renal denervation as long as you've confirmed everything else in all of the things that come before this. So you can see all the different things that you can screen for and look for in order for you to consider somebody to say they're truly uncontrolled, they've tried everything, now's the time to start thinking about renal denervation. And so where future guidelines, what we're waiting for in North America is specifically in the US, we're actually awaiting our American Heart Association's input for a new hypertension guideline. We're expecting these in August of 2025. For us in America, this actually is going to influence the widespread adoption of this technology, specifically because right now in America, there's very unclear payment mechanisms here. And so when we start talking about payment of these technologies and recognizing that there's going to be a key difference between how you guys practice in Saudi Arabia and those how we practice here, at least in the United States. But for single payer healthcare systems similar to yours, cost effectiveness analyses were already done, both for the private payer systems like us or a mixed payer system here in the United States. And for single payer healthcare systems like in the UK, both analyses are showing that this is a high value intervention where you can save multiple amounts of dollars for quality adjusted life years per patient. So it actually turns out to be a high value, low cost impact for renal denervation over the patient's lifetime. We do have single payers here as a healthcare option at the VA. And the reason why I'm saying this is because we are performing renal denervation under the guise of saying that this is going to be a cost-effective intervention. And so it's conceivable that some of these guidelines may actually change policy and payment in the future. And that's something that we're looking forward to here in the United States and certainly in North America when we get more guidelines. So that's the kind of general overview of the guidelines, both in Europe and North America and Saudi Arabia closer to home. They all kind of say the same things, but I think we're kind of trailing behind you guys in Saudi Arabia because we just don't have the definitive guidelines that you guys have. You guys are much more forward looking than we are in North America. So we're waiting to see what the AHA will say for us in August of 2025. And with that, I'd like to kind of stop my talk here. If there are any questions, I'm certainly happy to take them. But I think Dr. Cohen is going to follow up here with a lot more data on renal denervation.
Thank you very much, Ty. That was a really, I was surprised that you were able to get the Saudi data to be presented. Much appreciated.
No problem.
So we'll leave the Q&A later on after the talks. If you can stay with us, Ty. And we'll move on to the next speaker, with a great pleasure, from the same institution, University of Pennsylvania, Dr. Debbie Cohen. Dr. Debbie Cohen is different from most of us. She has a background of nephrology. She's a nephrologist. She's a professor of medicine at the Hospital of University of Pennsylvania. She's actually director of the hypertension program, director of the FIO and paraganglioma program, and also director of the clinical research of the renal division with an extensive publication. And we're going to learn a lot from her. The floor all yours, Dr. Cohen.
Thank you. Can you hear me?
Sounding clear.
Okay, good. Okay, thank you for the invitation. So today I'm going to talk about renal denervation as a concept and the evidence. Hang on. There we go. Okay, so firstly, I wanted to just start talking just briefly about resistant hypertension, because this is the biggest group of patients that renal denervation is considered to be appropriate for. So just when you look at the true prevalence of, or the prevalence of true resistant hypertension, it's actually quite low. It's probably about in the range of 2 to 10%. So most of people who considered resistant hypertension are actually due to apparent resistant hypertension. And there are multiple reasons for this, and I'm going to talk about this. And when I'm talking about this, I want you to think about the reasons and the types of patients we would include who would be appropriate for renal denervation. So I think the biggest reason for apparent resistant hypertension is non-adherence to medication. At least in the United States, this is a huge issue. Also, many patients are on complex medication regimens, and as you know, they're on a minimum of 3 drugs to be considered resistant, and sometimes many more, plus lipids, diabetes drugs, etc. Sometimes, at least as well in the United States, people do have financial barriers and insurance or access issues to actually obtaining the medications. And then a big group of patients as well is those with medication intolerances. I don't think, they truly allergies, but a lot of patients just can't tolerate multiple antihypertensive medications. And then we always want to exclude white coat hypertension or white coat effect. And so we do a lot of ambulatory blood pressure monitoring just to make sure that the patient it truly is hypertensive or truly resistant. And also important is to just make sure you're always measuring the blood pressure correctly with the correct method. And we do use the AOBP, that's the automated office blood pressure that we did in Sprint. Okay, so renal denervation is actually not a new concept at all. So this was initially, people did a general sympathectomy, lumbar sympathectomy, and you can see this is data from as early as 1931 up to 1953. There were these publications by Reginald Smithwick where they were doing sympathectomies, and this is before the advent of modern antihypertensive medications. But then, sorry, I don't know why my doesn't progress easily. I have to keep clicking. But if you have a look here, if you look in the orange, these are people that at that time they graded people in terms of hypertension severity. And you can see the group 4 is the worst severity of hypertension, and looking at their survival. And you can see that, this was pretty dismal, but this was before, modern antihypertensive medications. But when they compared it to people who underwent sympathectomy, they showed a definite mortality reduction and a reduction in morbidity. However, sympathectomy was associated with significant morbidity, such as, incontinence, impotence, GI issues. So this, as soon as the 1960s came and the first modern antihypertensive medications were being introduced to the market, this kind of fell away. But as we know, we have multiple different medications with multiple classes, which are generally very effective, but we still have all these patients with uncontrolled hypertension. And at least in the US, the rate of uncontrolled hypertension is over, it's well over 50%. So if you have a look here, you can see that generally what happens is we know we have this overactive, like inappropriate overactivity of your sympathetic nervous system. So at the level of the kidney, when you have increased sympathetic activity, you get increased renin release with RAS activation, increased sodium retention, and, which raises your blood pressure. And then this also, through your renal afferent nerves, has increased sympathetic output to your brain, which in turn increases sympathetic output, to your vessels, causing vasoconstriction to your heart, causing increased, heart rate, increased contractility, and back at the afferent nerves to re-stimulate the kidney. So really, how do we stop this? And what happened is that they started thinking about a catheter-based approach. In around 2000, could we do a much more localized approach with a catheter without causing all the significant morbidity that was associated with sympathectomy? And if you could do it at a local level and you could, stop this increased cycle of hyperactivity, you could lower blood pressure. So this is just some data looking at animal data, but what they did, you can see this is day 7 and day 180, and the blue is control and the orange is renal denervation. This was animal data, and you can see after renal denervation, up to 180 days, you saw this is a normal axon prior to renal denervation, and then afterwards you can see there's no staining for the axon. So we're getting reduction in cortical axon density, as well as reduction in norepinephrine concentration. So just showing proof of concept. And another important thing that we learned from Simplicity HTN-3, because there were a lot of learning, lessons from that study that we took part in. And one of the things was they really went back and looked at the distribution of the nerves in the renal artery. And you can see they are different. Proximally, they're more evenly spaced out, whereas you can see distally, it's more dense around the center here. So really what we realized from those studies and, these animal studies, that you need a complete 360-degree ablation in order to achieve successful renal denervation. So they actually, Medtronic at that time came up with a new design of catheter where you could get renal denervation in 4 quadrants at the same time. So this is really the timeline of renal denervation. So this was initially when they started thinking about this catheter-based approach. This was, HTN-1 was an unrandomized study, and so really was HTN-2. And then we had this big landmark study, HTN-3, and really prior to that, we were pretty confident that renal denervation would be approved at that time, because the preliminary data in HTN-1 and 2 showed very good reduction in systolic blood pressure. But what happened, this was a negative study at the 6-month primary endpoint. Was very disappointing at the time. But as I said, there were a lot of lessons learned, and they went back to the drawing board. And then there were 2 types of, at that point, there was an ultrasound device, that was being tested, as well as the renal radio frequency ablation. And all these studies were done in patients either off meds completely with hypertension or on meds, depending on the device and the study, but 1 to 3 meds, and they were all done with sham control. So this was, and HTN-3 was done as sham as well. But so these studies were done really, really well. And, this was either the make or break of renal denervation. And renal denervation was actually approved in the United States for both types of devices, the renal radiofrequency ablation and the ultrasound, in November of 23. So this is just what they look like. I mean, I'm not sure, if you're familiar with all of this, but this is the RFA device from Medtronic. This is a spiral catheter. It's done in the main renal artery as well as the branch arteries. It does take longer than the other device. And you can get, 4 ablations because of the design of the catheter. And, both of these, I'm not an interventionalist, but I could answer to this, but I think both of these systems are fairly easy to use. Now, the ultrasound device is different. This is, you only use it in the main renal artery, not the branch arteries. Has a special cooling device in the device. So in the center, you get the ablation, and around the edge of the device, it cools the artery so you don't get burning of the artery. And this takes much quicker because you're only doing the main renal artery. So let's look at the data. So this was a primary endpoint for all the different studies. So you can see this is office, this is ambulatory, this is the HTN3, which was a negative study. You can see there's very little difference between sham and the treatment group. But now if you look across here with the newer designs, spiral studies are all with the RFA device. So this is on-med and off-med, and Radiance is with the ultrasound device and from Recall. And you can see here that overall, and these are all different time points because that's how the studies were designed, but it's between 2 and 6 months where the primary endpoint was reduction in systolic blood pressure, and both, ambulatory and office they looked at. And you can see there was a consistent reduction of about 5 to 10 millimeters in all these studies. So, but this is at the early time point. And what's also been shown is that you can see that over time, this is 3-year data, more patients are in the range that we would consider normal or well-controlled blood pressure, as well as you can see there's a reduction in the number of medications used, generally over a 3-year period. This is data from the Radiant study. So these are all the ultrasound studies, solo, no meds. TRIO was 3 combination pill, and the chief study was a different study done in Europe. But what you can see here, up to 3 years, you're getting maintenance of your systolic blood pressure reduction. And overall, I'll show you some more data, but it looks like at 3 years, you're getting about close to 20 millimeters of systolic blood pressure reduction. Then this is the ACHIEVE study that I showed you, 12-month data, but here this is data through to 8 years. And you can see here that even at 8 years, you've got durability. So this, they were concerned about regrowth of the sympathetic nerves, but you can see this doesn't seem to be the case.
Dr. Cohen, we need to conclude in 1 minute.
Oh, okay. So let me just quickly say that you can see this has an always-on effect in the ambulatory blood pressure monitoring as opposed to medication. And then we also have data from very high-risk groups of patients, and we have 3,200 patients that were in a registry, and you can see renal denervation does work in all kinds of high-risk populations. And this is also data just showing more reductions that have been durable past 5 years. And just want to say quickly, there's no safety issues at all. You can see this is both kinds of devices, no safety issues. And here you can see with people with chronic kidney disease and without chronic kidney disease, no change in GFR. And this is just quickly, just show you this quickly, the 12-month data now, and then the 3-year data, this have shown that Simplicity HTN3 was actually a positive study. I think they just didn't wait long enough. And just the only consistent characteristics associated with response to renal denervation is your starting blood pressure. So the high baseline, the more likely to respond. I'll just skip over this, but you can see that this is kind of what Ty went into, which kinds of patient would be appropriate for renal denervation. So in resistant hypertension, intolerance to drugs, and non-adherence. And I think that's my last slide. So I won't go over the summary, but I'm happy to take questions in the later session.
Beautiful. Thank you so much. That was really comprehensive. I like the last 2 slides are really, we might steal it from you later on. So thank you very much. We'll leave the questions at the end. I believe next is me. So I'll share.
So I just want to thank you so much, Dr. Cohen. And I want to introduce Dr. Waleed Al Harbi is well-known interventional cardiologist, and he's head of cardio department at King Saud University Hospital. and he's gonna present his case in details. And mic is your Dr. Waleed.
Okay. Assalamu alaikum jami'an. So I'm not gonna present the case. I'm very thankful to Dr. Kobayashi that he spoke briefly about hypertension in the kingdom, and I have nothing related to this topic. And I'm gonna talk about the prevalence of hypertension in Saudi Arabia. It's based on the regions, there's a reporting bias, but from the WHO data, it's about a third of the population from the age 30 to 80 from the 2019 statistics are hypertensive. And if you look at the percentage that's really controlled, it's about only 20%. And that's reflects the compliance worldwide. And as we know, hypertension is the number one factor that's contributing to cardiovascular death. And if you look at the impact of hypertension compared to other risk factors in different registries, studies, hypertension really go in the high ranks. And the cardiovascular mortality actually doubles with each increase of systolic of 20, diastolic of 10, increase in blood pressure. I tell you how important controlling hypertension for our patients. And if we progress as we are, we're gonna have, we're not gonna really reach the vision of the kingdom of 2030. If we're able to progress well and with better control, the percentage from the 21%, and we try to optimize that, if you reach at least 50% of the population with controlled hypertension, we're going to avert about more than 125,000 deaths by 2040. So it's really important to reach control of the hypertension, which is a very major gap in our population. So back to our patient, the issue is we have compliance issue, and we have half of our patients stop their blood pressure medication within 1 year, and that's a major issue. And with the advent of drug inventions and discovery over the years, one after the other, we still only have only quarter are controlled hypertension of the population. So it's a really major issue despite the medication evolution over the years. So we have options that work, that with lifestyle, and in our kingdom, we have obesity is a major issue in all of the Gulf region. Obesity is, we believe it's a major contributor to hypertension, and that was reflected in the Pure Saudi study. And salt diet also is an important factor. And you can see that obesity prevalence is pretty high in our kingdom, and is even more in women. And that was in the earlier years. And hopefully with the newer data, we're gonna see improvement in that aspect. Medications, the compliance issue that we're not able to reach, hence the technology been introduced as an intervention if we're not able to control all the lifestyle medication, and that's where renal denervation have a role. The downside of renal denervation is that they say the effect is very small, but even small reduction in blood pressure, there's a reduction in cardiovascular mortality. So in a 10% reduction, if you decrease by 2 millimeter in a population base of your mean office systolic blood pressure, you have a 10% reduction in risk of stroke mortality, 7% reduction risk of ischemic heart disease mortality. But that's understood in a population base. As my colleagues introduced, that there's 2 technologies already approved in the US, and we have the Medtronic and the ultrasound now in Saudi, with different technology, but the same probably the goal of the outcome of the intervention. And the efficacy actually of the renal denervation increases over time. And so you have to be patient. You don't make that judgment early on, and you wait up to 36 months to see that effect. And go back to the patient selection, as Dr. Cohen alluded, is that patient selection is very crucial. So it's not everyone really exhausts lifestyle, weight reduction strategies, compliance with medication, and that's where the 2 to 10% of patients that require renal denervation and labeled as refractory. Make sure that you rule out secondary causes, where you comprehensive workup is done beforehand, and make sure that the anatomy is suitable for denervation, and make sure there's no any atherosclerosis stenosis. So rules to proceed for that denervation: make sure you hydrate the patient to reduce risk of sin and make Dr. Cohen happy. The antihypertensive medications, do not stop it before the procedure. That's usually what I do. And really recommend deep sedation as much as possible. So be generous. Not only conscious sedation, you might consider deep sedation. When I'm saying sodium champagne, I'm talking about fentanyl, midazolam, to make it patient as pain-free as possible. Always start with a non-selective aortogram, so we can identify if there is any accessory renal arteries. This is an example. So you need to complete your denervation process. Sometimes you're going to have surprises that you have only 1 kidney. And next step, you do a selective renal angiogram and try to analyze and plan your attack and how you're going to tackle the denervation. As Dr. Kobayashi and Dr. Cohen mentioned, that you really make sure you do a proper 360 degrees of denervation ablation. Sometimes you have a lot of tortuosity, and that's where you're going to use more extra support guide wires if needed, not to struggle like in this case, where you try to wire and then try to introduce the catheter, despite you didn't really introduce the wire up to the end, just fearing where it's going to go. And then you're going to have a struggle that your catheter going to be really looped out. You might cause injury to the renal artery. So whenever you feel there's tortuosity, and that's where the selective renal angiogram help you to plan your gadget and attack plan. And like anything in life, beware of dissatisfiers. Happiness equal reality of expectation. You're going to be frustrated if your expectation, you're going to have dramatic improvement in your blood pressure. So you have to manage your expectations with your patient and yourself, and present the data and share that data with your patients before you embark, so you don't be frustrated and your patient not be frustrated. And as alluded earlier, it takes time, and wait, and don't rush judging the efficacy of the denervation. And in a nutshell, I just want to reinforce that make sure you have the right medication, the lifestyle, compliance before you embark on renal denervation strategy. And really emphasize that before referring the patients. Exhaust every lifestyle factor you can do with your patient, especially with weight reduction. We've seen this with surgical bariatric, new obesity medications. You see dramatic improvement in their blood pressures. And of course, obstructive sleep apnea, make sure that does not play a role. Food counseling, salt counseling, and remember how to really counsel the patient. Refer to a dietitian to do a better job than us as physician when really have no time. And that's it. We'll leave the questions for later on. And Dr. Ahmed, who's next?
Thank you so much, Dr. Waleed, and it's really as a matter of it's like multidisciplinary approach is not only like to do the procedure itself. There are many things should be addressed, and as being addressed in the guidelines should be center-based hypertension, and that gonna get the effectiveness of this procedure. So I'm gonna just present a quick case I did like maybe 6 or 7 months ago, and so I have no disclosure. So our patient, 61-year-old gentleman with the diabetes mellitus A1C 6.9, good treatment, and his dyslipidemia and LDL 1.9, and parameters hyperplasia and hypertension diagnosed for more than 20 years. And hypertension history, yeah, our patient is a medical professional. Actually, he's a consultant neurologist in our hospital, and he's been diagnosed with hypertension for more than 30 years and started initially in dual or double agent for a short time. And because his pressure wasn't controlled very well, so they add 2 more medication to control his blood pressure. And at that time, secondary cause of hypertension being worked thoroughly and been excluded. Okay, so and he used to measure his blood pressure at home regularly, and his average day time between 130 to 160, and that's between 80 to 100. And nighttime a bit low. However, there is some occasional his pressure reaching 170, 180 sometimes. And his current medication, including lisinopril 40 milligram daily, nifedipine XL 90 milligram, and hydroxyzide 25 milligram, and bisoprolol 10 milligram. So he's in 4 medication, despite that his pressure and control. Spironolactone being added that time, but I think he had some side effect that he stopped it. And you can see this is medication from our system here. And you can see this is another thing for our population. They have not only hepatitis, they have like this, they have diabetes. So they have a lot of medication we use. This is why the compliance and adherence is an issue for most of our population, or for the patients. The benefit and risk of this procedure and what and will proceed. So when bringing the cath lab, I use 6 French right from machine with ultra guidance, and I usually use micropuncture for my femoral axis, and I use the 6 French IM catheter 65 centimeter, and I use cyan blue wire for the procedure. I didn't use like a other stiff organ slam wire as recommended, because sometimes, as the doctor mentioned, you have torsions, difficult to advance those wires somewhere. If you need, sometimes you need like body wire to help you. For French simplicity, parametric electrode Ardeen catheter. And so this is the selective renal angiogram. You can see the left kidney and the right kidney, and there is on the left side you can see there is like accessory artery, and the right side was clean. So after that we start the good sedation, as before, should be sedated very well. With and fentanyl, and be aggressive, and because it's painful for the patients. And after that, we start the procedure, and we did, I think, around 34 application for both kids. And the procedure went very well with no complication. I discharged the patient the same day. And we usually call the patient after days, sure no issues with the procedure, make it was still compliance with medication with no any interruption. Then I saw 6 months, that I think was a month ago. I mean, I did not blood pressure media by ward 24 hours blood pressure monitoring, and over 75, which is did you hear me, guys?
Lost the connection.
Yeah, but we are not hearing him.
Dr. Ahmed. We lost you.
Yeah.
We lost you for the connection is not stable, but are you able to share again?
Now, did you hear me now?
We can hear you, but
Yes. So have you seen this? I think so, huh? Have you seen those slides?
I can't see the slides. No. Able to share them again?
Okay. Yeah, I will.
Unshare and share.
I guess Waleed, while he's pulling up the slides, I think this I get this question a lot about what's the prevalence of accessory renal arteries and whether or not you need to treat them. Do you want to kind of mention or discuss accessory renal arteries in your practice? What have you seen?
Yes. If you can, Red Sank, if you can mute non-participants, yeah. Yes, for the accessory renal arteries, I don't know the percentage out of my mind, but it's pretty. I'm not saying it's common, but I've seen them. Like probably so far in my practice, I witnessed them around. I assume it's about 5 to 10%. I don't know what's in your practice.
Usually, if it is a large accessory, for sure I ablate. If it is small and is covering small portion of the kidney, I leave it alone. Especially if I did good amount of ablation to the main artery and its branches.
The question is that how frequent do you see it?
Yeah, it's not much, maybe of 5 to 10%, like 1 in every 10 that need ablation.
Okay. What about you?
Yeah.
What about you?
Yeah, like we're actually seeing a little bit more percentage wise. I think it's been reported up to 30% of patients that undergo the procedure have some sort of accessory renal artery. And for us, like, as we kind of stick to the guidelines of like what the industry partners would like us to do. So any accessory renal artery that's between 3 to 8 millimeters in diameter, you want to treat. With the caveats that are already kind of been discussed, which is that if they're too small or if it's not really important, meaning as defined by less than 20% of the kidney parenchyma, we usually leave those ones alone. But anything that's 3 to 8 millimeters, any target, anything that goes to the kidneys within that range is fair game. So the case that was just presented, that was a pretty large accessory renal artery on the left, and that would have been a good target to chase after. And so some folks have been asking me like whether you need to chase after that one too. The answer is yes, typically.
Excellent. Thank you very much. Any other questions? Or Dr. Ahmed, we're able to get connected again or no? If not, we can move on to the next speaker. Dr. Faisal Al Nasser, are you ready?
Yes, yes.
Yes. Okay. The floor is yours.
Dr. Waleed?
Yes, we can see you, but we can't see the slides. Yeah.
I given the slide to. He said that he will.
Yeah,
put it
just
in.
1 second. 1 second.
What is the prevalence of accessory in both sides? Do you have any idea, Dr. Kobayashi? Like, is
You
it
know,
common?
it's not common. I will say that usually it's like two on the left and one on the right, or vice versa. But you know, there are definitely some accessory renal arteries. I think Waleed, you had showed a case where there was an accessory coming off at like L4 or L5, like going all the way upwards. Those are the ones that I think you want to be careful of, because, and that's part of the reason why we typically start with a you know, a non-selective aortogram, because some of these renal arteries, they come up from way low and start going higher. So just
Yeah.
not to miss those ones. Those ones are always harder to even cannulate and get into, but you know, we've had a couple, like maybe two in the last 80 or so that have come off at like L4. Those are the ones that you don't want to miss.
And if you just allowed me for Dr. Faisal start, just I wanna share one thing here. Like this is a case I did 2 days ago. Just to get what the people think about this. This is a patient. She had rheumatoid arthritis.
Ahmed, we don't see your slides. You want the
Yeah,
uploaded?
yeah, just like one slide only. Okay. So I did this case like 2 days ago, and this 55 rheumatoid arthritis, obese, hypertension, and diabetes, and so she's in 5 medication, uncontrolled blood pressure, and so this is I did like aortogram, nothing good, so no X-ray, and did like this selective angiogram, and after that. I start my procedure, but I noticed the impedance was high, temperature was high, and because the safety, the system was stopped by itself. So my concern was could be there is a spasm or there is something. So I give like nitro, like 200 nitro, and still not response. I pull back the catheter, and this is what I found. And you can see clearly there is like spasm here. And after like nitro, adenosine, and verapamil, that doesn't go away. So the question now, just we can discuss later on, shall we proceed, shall we stop, or we call for a day and that's it? And what do you have to do for those patients? Maybe this can be discussed at because of time, we can discuss it at the end of the panel or the webinar.
So
Thank
I had a similar scenario a couple of times. I think Abdullah Saidi presented one case recently. Usually they respond to verapamil and nitro, but if one of the case was similar to your case, we could not eliminate the spasm. We did the IVAS just to make sure there is no dissection or something we are missing. Then it was clearly spasm. We could not complete because the machine will not allow you to go. The impedance will be very high. So the important thing is if the spasm did not go, you have to make sure there is no structural reason like a dissection or something like that.
Dr. Kobayashi, what would you do?
Yeah, vasodilator, certainly like we use radial cocktail, so verapamil nitro. I've only seen this once. And you know, the Medtronic, I was using like a mailman wire, which has a hydrophilic tip to it, but it has that, you know, stiffness, the shaft support. And they were claiming that they've seen like, you know, large vasospastic reactions with the introduction of the catheter, with more often than not with hydrophilic tips. And so, you know, that's when we kind of switched over to mostly like Grand Slams and only Grand Slams or BHWs as our wires to make sure that we kind of got away from this. And when I did do that in the middle of the case, it actually did make it better. I don't understand the mechanism, but you know, I can tell you from just one case of N of one, it seemed to work. So I'm not sure. I've seen this once, and you know, the way that I got around it was to switch out wires.
So what did you do, Dr. Ahmed?
So yeah, so what I take the microcatheter inside, I give like a nitro and verap and adenosine inside the renal artery, but it was the same, a bit improvement. Then so it was, this is the first I showed the left kidney, the right kidney, sorry, and it was okay. Then I moved to other kidney to start the procedure. Just by advancing this one ablation only, and I noticed that I pulled back and give a lot of medication, but it wasn't respond. And then I put the procedure and I keep patient observation for like 48 hours, and I do blood like kidney profile in 2 days. The kidney function is still the same, no like baseline normal. So I stopped. I don't know, but I mean just the kidney function is still like normal, and
Yeah.
like 10 days I'm gonna do kidney function, make sure everything look good. But
Yeah.
I think the message here, as Dr. Waleed mentioned, you might use like IVs, make sure no structural problem, and just stop, don't proceed, because now become a safety problem.
Excellent.
Yeah.
Thank you
Yeah,
for
Waleed,
sharing.
just quick question, if you allow me. What wire you guys use? So Dr. Kobayashi said, the slam wire. What do you use, Waleed, Ahmed, Faisal, the other in your practice? What is your workhorse wire? I personally use cyan blue, and it worked very well.
Me too.
I usually use a non-hydrophilic because of risk of perforation, and quarter tip design guide wires like Xi'an blue. I usually use turn track, a guide wire, what we have in the lab. But yeah, but unless
Ahmed, what do you use,
I'm
Ahmed?
suspecting I'm using if there's tortuosity or I'm suspecting difficulty, then I would use like what Dr. Kobayashi mentioned, a bit a stiffer core.
Yeah, so I do the same thing. Like I use like a cyan blue wire, BMW. But if I have like difficult to advance the equipment, I use like body wire, and work very well. Because the ground slam sometimes difficult to advance it all the way. So sometimes because of the tortuosity, so I use the body wire to work very well. So yep.
Very good. Thank you, Dr. Ahmed, for sharing this case. We'll go to Dr. Faisal Al Nasser. Back to you again.
Alan.
So,
Yes, let me-
Dr. Faisal Al Nasser, he's director of a cardiac center at Medina, well-known interventionist, and we're happy to have him. The floor is
Thank
yours.
you. Thank you very much for giving me this opportunity to present and to be shared with you the case that I did, and we are starting this about more than a year and a half. Before that, we started before, but we stopped it, and then we returned back, about 1 year and a half. And actually, our experience with this is a good one, but it depends on the things that you said, and I will mention it. First of all, as you know, but we are presenting the things also for the people that with us in not specialized in these things, that hypertension is a global health crisis. And in developed country, actually, we found that 50% that only they are controlling their blood pressure, but in developing country, the percentage is really, really less than that. So the importance of it, as everybody know, that even with it is hypertension was leading to preventable causes of heart attack and stroke and death. And usually, even with, as Dr. Waleed mentioned, and with minimal reduction in blood pressure, there is a really significant effect in those parameters. However, we found that there is non-adherence in developing country, which is very clear. It's more than 45% that they are not adherence partially, and totally it's higher. But in developing country, this percentage is really higher than this. So it is the most important things in treating the patients, or treating the patient with other than treatment which is available in our that we are using to patients, is actually selecting the patient that they are not controlling the treatment that's not controlling the patients. We found that to build a proper controlling to the blood pressure, and to be really get a benefit from this, all the things provided to our patients. We found that to be, should be a specialized clinic look after hypertension, and those hypertension that they are resistant to treatment and they are not responding to treatment, and then we take them gradually to be offer them the new things, which is denervation, other things. So the kidney and renal denervation is also a rule in the treatment, but it depends on the selection of your patients. And as you know, the denervation, the main or branches or main and branches is important, and there is significant effect by doing the main and the branches. So we found that the reduction is really fast, even after 24 hours. We found that there is a response, or there is effect of our treatment, our new treatment, on those patients that they used not to have a real control or reduction in their blood pressure. The most important things that we found, as the guideline mentioned, and it is selection of the patient. And the selection of the patient, it should be really the most, or the money, it should be on the selection of the patient and how we can select the patient in a proper way and follow up those patients and try to not to stop or to think that there's a stopping of their medication by using this modality, but by follow them and reducing the dose. And then if you think that is necessary to reduce or stop some of the medication and keep them on the minimal medication that they can control the blood. All the guideline actually strongly asking the treating to be selecting a proper patient for a proper medication. And so for the renal denervation is a safe and effective treatment to control blood pressure, but you need to be selecting the patient properly. So I would like to share with you my case that I presented. I did it a few months ago. And this patient, she is 52 years female. Her weight is 83, and heart rate was 100, and with history of diabetes and elevated blood pressure. Complaining of headache, dizziness, and on and off since many months, and she was on regular medication, but they did not do much any improvement with those medication, and her blood pressure all the time is high. So we found that the patient, she is ischemic heart disease. We did for her PCI for her LCX and RCA. Her lab was normal, and CT scan for abdomen. There was no any sign of secondary causes of hypertension. We measured her blood pressure in the upper arm was 186 over 107. Right lower arm is about 205 over 101. And she was followed in our OPD, and she is in for medical treatment for more than 6 months, and still the blood pressure the same, and there is no response at all. So echocardiogram, cardiography was normal. There is only the concentric left ventricular hypertrophy. Other than that, nothing to be mentioned. Of course, her consent was taken, and the patient symptomatic despite being on all this medication, and never the blood pressure never controlled. So we decided to do for her the renal denervation. So we did actually, this is an important issue which you mentioned, but sometimes it's a difficult anatomy. It's a simple procedure and can be done simply, but sometimes there is, you will take a lot more time than expected. You should be patient while you are doing your case and try to do the main, and you should be doing only the necessary ablation that you think that it will be effective in your treatment. So we did actually found that the patient, we ablated the right kidney. We did about 13 in total, 2 to upper and main and middle and lower. In left kidney, we did 12, mainly in upper and the remaining in the main one because it was really long. I don't know, it's what. Just, I would like to show here the in the last slide the long the main artery, which is needing more ablation. So after that, we are regularly followed the patient, our patient in general. We are followed them in our specialized clinic, but you cannot put hypertension clinic because it will be full from the next day. It should be for selected or high selected patient hypertension clinic, which is not responding to our regular medication. So we followed up the patient for more than now about more than 6 months, and we found that blood pressure actually getting control from the next visit was controlled on those 4 medications that she was on, and was controlled. And then in the other visit or the next visit other than that one, we found that we reducing one of her medication and still the patient in controlling her blood pressure. And the patient actually, she's feeling better. And symptoms started to really be away. And the patient was thanking us for this. And the patient getting better.
Thank you very much,
This is,
Dr. Faisal. That was a great case. You showed us that there was a struggle in delivering the catheter over the wire.
Yeah.
What
I mean,
techniques you would to overcome that? And we'll hear from Dr. Kobayashi also, and Dr. Ahmed, and Dr. Naif, Dr. Wal, if they have any tricks and tips for that.
Actually, which for all our interventionists, coronary, they are deal with all the things. But sometimes we are expecting to do the things into 15, 20 minutes. Sometimes we are taking long. So the patient, the doctor should be patient. Some of the time is not an easy things and taking longer time than expected, but it's doable. It's not something that need
Like a chocolate box. You're right. You never know what's going to happen. Any comments from Dr. Kobayashi?
Sorry, Dr. Kobayashi. So, I think as Dr. Faisal mentioned, it's not something like very complex. We deal with more complex than this. But I think that the safety is here important because sometimes that can damage the arteries. So still, I believe using like body wires. If you notice air resistance, just body wires, they may give more support, and that's gonna help you to straighten the artery a bit, and you can advance the catheter safely instead of pushing up and do damage the arteries. Thank you. I'm not sure.
Thank you. Dr.
Yeah,
Kobayashi?
I agree. I think like one of the hardest things is not only tracking the catheter, but also to engage some of these more tortuous renal arteries. And for that, like, you can take advantage of the spiral shape if that's what you're going to be using. Most of these cases that you're showing are Medtronic. And for those, like, you can always use the actual helical shape of the microcatheter to engage some of the ostium of these like really tortuous ones. And then, kind of point and push the wire in that manner. I will say that, for the ReCore devices, which is just the main branch alone, to be honest, because it's just the main branch, you don't really need to utilize any sort of like, super stiff wires. Like I've done it over a run through wire. But obviously it's a completely different sort of platform and technology, but it is available. It's, at least in the United States, it's FDA approved. And so it's a sort of another another option for those patients. Like if you're saying like it's really too hard, I tried really, really hard to get down these distal branches and I can't get it there. Main renal artery alone denervation technology does exist. And there are going to be more coming down the pipeline.
Yeah, I really, I'm wondering, like the main artery ablation devices, they are going. I'm not able to buy it, to be honest. I haven't seen major studies about it, but or robust data about it. We are going to square number one when we used years ago to do only main artery ablation, and and that was the reason why the RDN failed at that time. I still strongly believe that the branches, the mid branches or the second generation branches, the juicy one, need to be ablated. I don't know how the main stem alone are gonna make a difference. There is, if you look at that to me and the initial anatomy paper, maybe Dr. Debi, she can help us. Still, there is a lot of autonomic nervous system around the second generation branches. So I wonder how this still is too early for the other devices based on only main renal artery denervation. It show like a good benefit. I'm still waiting for data for that, but anatomically there is a lot of autonomic nervous system around the second generation branches. So this one need to be tackled. Regarding the tortuosity, this is the if it is really tortuous, this is the only time I use microcatheter, advance any wire at the beginning and go as much as you go distal, then put the stiff wire, then do the ablation on the stiff wire.
Okay, very good. Thanks for your insight, Dr. Waleed. So we'll go to the next speaker, Dr. Mohammed Al Mansouri, an outstanding interventional cardiologist from King Fahd University Hospital from the Eastern Province. And the floor is all yours, Dr. Mohammed.
Assalamu alaikum wa rahmatullah. Let me share my slides. Do you have my slides?
Yes.
Okay, good. So our group has been doing renal denervation, I think, since 2013, and at that time we were using the Simplicity catheter, doing 6 to 8 ablation in each side. People doing the renal denervation nowadays, the procedure became more aggressive by doing kind of 20 to 30 ablation on each side nowadays. So in spite of that, we had very successful stories with the Simplicity catheter at the time. Anyway, if I learned something from a renal denervation procedure, we do not screen enough for secondary causes. And because of the those patients with resistant hypertension coming to our clinic now, we start doing these more and more, and we start to catch a lot of these secondaries. And over the years, I came across few patients that our group did a redo denervation on them. And among all these few patients, they all had similar result to the one I'm gonna share with you today. I don't know your reflections about that, but let us see what we had. So this was in October 2021, a 30-year-old male with classical risk factors, screened for secondaries by his referring physician before he come to my clinic. He was on Amlor 10 milligram, Carbidopa 25 milligram twice a day, thiazide, and a full dose of perindopril. And his blood pressure on the 24-hour Holter monitor was averaging 180 over 100, with very frequent readings more than 200. Now, going back to the Simplicity trials and the spirals. An ambulatory blood pressure above 180 was an exclusion criteria. So if you keep doing those with very high blood pressure, you may not face the same result obtained from the studies. So his average blood pressure was 180 over 100. So at that time in October, he got 16 ablations in each renal artery. Now, in September 2022, the patient was only on Amlor 10 milligram and Kodayovan with these numbers obtained from his ambulatory blood pressure. Daytime averaging 128 over 80 and nighttime 117 over 71. Excellent numbers for someone with his baseline characteristics. He disappeared for some time and appeared in August 2023 on this medication, seen by somebody else, changed his medication, and now his ambulatory blood pressure showed these numbers. Daytime 165 over 102 and average nighttime readings 167 over 98. I tried to adjust his medication and now he is on this medication with better blood pressure control, yet not in target for someone with hypertension and diabetes. So this was in September 2023. So he requested a repeat procedure himself. So given the previous experience with the initial result, he requested another procedure. So this time I did 11 ablation on the right renal artery and 21 ablation on the left renal artery plus the accessory artery. Now this was his right renal artery. And this was his left renal artery, and this was the accessory artery. It is a common finding to see an accessory artery. And personally, I'm very keen on doing these accessories. Some of the evidence suggests that there are very dense nerves around those accessories. So if it is meeting criteria to be denervated, I'm very keen to be very aggressive in ablating these accessories. So in February 2024, after the second ablation, his blood pressure was almost the same, averaging 144 over 89 daytime and 136 over 87 at nighttime on the medication. And a few months later, he came with his blood pressure rebounding back to averaging 160s over 100. And I remember I saw him one more time after that, and his blood pressure was in the same range. So the other few patients that we have done a redo RDN on them, they ended up really with the same result. Not as impressive as the first denervation. I don't know if this was looked at in studies. I don't know what are the experience with you guys, if you have came across something similar to this or not. And thank you very much.
Thank you very much, Dr. Mohammed. That was really insightful. Any comments, Dr. Tai?
I will say that like repeat ablations or repeat denervations, I get asked this as well, is like, do you ever see a lot of patients having to get a redo denervation? And the answer, I think, is it's very rare for folks that have undergone, 2 denervations, something like this. It's not to say that as we start to get more experience with this, and I think I'm going to answer one of the questions here, which is to say, how do you know if you've done enough? So what is the number of ablations required to kind of prove the efficacy and to prevent a repeat ablation? I mean, I don't think anybody knows the answer to this right now. And I think it's extremely rare to see folks undergo a second ablation. So I don't really have experience with this, Debbie. I don't know if you do, or have seen anything or heard anything where people are undergoing secondary denervations.
I mean, we haven't, I mean, we haven't done any secondary denervations. And I mean, the only thing I would say is that I have still some patients from Simplicity HTN3, which is, that was published like 2013 or so. And I mean, people have, like, some people just seem to have incremental responses over time. So I think someone said this earlier, but the initial response isn't what you're going to see over time. But obviously patients have to work on lifestyle, weight loss, all those other things. But we have seen, I mean, I've had patients who over like, the 10-year period have actually come off most of their meds. But I mean, that's not a rule for sure. But I mean, we haven't, I think just because we're cautious, we have not redone any renal denervations that didn't work. But truthfully, from the first studies, I mean, it's possible that they didn't work because they weren't properly denervated.
Thank you very much. Yeah, Dr. Cohen, what about, there's questions about how to build a good program for renal denervation. What do you suggest?
So, I mean, we talk about this a lot in the US because, a lot of people want to kind of get on board. But I think the most important thing is that you have to have two groups in the program. One is like a hypertension specialist who's going to, evaluate the patient properly, because another thing, and I wrote it in the chat, is a lot of patients who don't respond. I think a good portion of them have primary aldosteronism and they never worked up. So you have to have someone who's going to take the time to work the patient up, make sure that they don't have a secondary cause of hypertension. And probably a third of patients with resistant hypertension have primary aldo. So I would do that. And then, we set up like an ambulatory blood pressure monitoring program, all the things that you can, you need to do to make sure the patient gets good care. And then when we exhaust that, and we've also, have appropriate medication, appropriate dosing, etc., then, then we will send them for renal denervation. Or, in the patients that just honestly do not take their medication, I mean, there's nothing we can do, so those are the patients, even if they don't need a lot of medication, it's better to do renal denervation than them, having like high blood pressures, even if it's a 160 and strokes, heart attacks, etc. And then, the intolerance group, it's a strange group because, like a lot of people aren't truly intolerant, but I mean, those people, it's the same thing. If they're not going to take the meds, for whatever reason, that's a good group. But I think it should be team-based approach. We work very well together as a team, but I think that, because I don't like the interventions, a lot of interventions may not be as ethical to deciding about whether the patient needs renal denervation, because at least in the US, it's very like, commercial system, so they're going to make more money. Whereas for me, I don't gain anything whether they go or not, but like, I feel like we have, my group, they have, more like ethics in deciding who goes forward.
I agree. That's a very important point, Dr. Cohen. You're right. That's why we made the decision that nephrology, the hypertension clinic, run by a nephrologist, so they are unbiased regarding us interventions who like to intervene. So we make that decision really solely, heavily on the nephrologist who's running the clinic. We have a refractory hypertension clinic in King Saud University. Hopefully, and that's what you propose, that the hypertension clinic be done by a non-interventionist. I agree with
Exactly.
this.
I mean, it could be like an internist, a cardiologist, nephrologist. I mean, the AHA actually has excellent resources for like what's required for a hypertension center. And I mean, they're online and easily accessible, and I would recommend that. Because, it just tells you like, because we also find people, we work, if we have primary aldosteronism, we're going to treat it. And we see a lot of actually pheochromocytoma, but we do have a specialization in that. We treat them renovascular disease, FMD. So, you want to have a comprehensive program so that you can deal with everything that comes along.
Excellent. This is a segue to Dr. Naif Al-Majid talk. He's a really interested I think he developed a hypertension clinic in the future city of Neom. He's a director of cardiovascular services, and the floor is for you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks for the invitation and giving me this chance. Actually, I started the advanced hypertension clinic in Al Riyadh, not in Neom yet. So just I'll give you my short experience in Al Riyadh when we started the advanced hypertension clinic. So I will present two cases very shortly for your valuable time. I have nothing to disclose. The case number one is a 53 years old lady with background of 10 years of hypertension, antihypertensive medication, no evidence of target organ damage, hypothyroid. Her average office blood pressure in the referral letter was 180/100. She was in 5 antihypertensive medication with quite high dose. So she was referred to our clinic for further management and possible RDN. And her initial doctor, he exclude the secondary causes using the imaging and labs. So in Riyadh, we have built a local pathway for our clinic. And we were lucky, like we have a clinical pharmacist and nurse educator in this clinic, along with a family medicine physician who is interested in hypertension, and he's running that clinic. So all patients should be go to the first step where they initially assessed by the nurse educator review and clinical pharmacist. The nurse will teach the patient about the technique of blood pressure monitoring and try to get a like an accurate blood pressure reading. Because I believe that we have a lot of aberrant resistant hypertension rather than the true resistant hypertension, especially with a lot of referral from our colleague in telemedicine. The clinical pharmacist, the main thing is optimizing the aortic dose in those patients, especially like we don't have time to wait for them for optimizing this aortic dose. So our clinical pharmacist did a great job in that, and he's doing an evaluation for the adherence assessment for those patients. After that, they will go to the second step where the resistant hypertension confirmed and the pseudo-resistant hypertension, I will say, excluded. Then we'll exclude the medical secondary cause because we have an access for some labs that not available in medicine clinics. And we confirm that those patients, they don't have a secondary cause. Actually, as Dr. Mansouri, usually patient with very high crazy reading like 80, 180, 200, I don't think they are, we need to take our time before considering them for RDN. Then we go with the same step that endorsed in the international guidelines. So this patient, back to our nurse educator, she said there is no home blood pressure reading before at all, no ambulatory blood pressure monitoring done for this lady, and she wasn't aware about the difference of the medication. She just get each visit, she get a new prescription without knowing an exact medication, and this is very important. And those patients, it's a little bit weird people that they might have intolerance. It's very difficult to get them adhere to the medication, and usually they give us a lot of like symptoms or side effects that we could not relate it to the underlying cause. So they need more effort, especially with our nurse educator, to convince them about this medication and try to figure out what's the problem with those patients. Our clinical pharmacist, he conclude that she had a low adherence to the medication based on the Moresky adherence scale, and she was avoiding the thiazide or the diuretic because of the diuretic effect. She wasn't on the thiazide really. So after close follow-up and subsequent session over a month with our nurse educator and our family medicine doctor in the clinic, training in the correct blood pressure monitoring at home, ensure lifestyle changes, they ensure that she lose some weight, her average blood pressure back to 128/84, and she didn't need this procedure. And we get her a combined tablet, like she just get one tablet, and all of her problem was okay. She wasn't exposed to invasive procedure, and we ended that. But it takes a long time, like maybe like 2 months with repeated session with the nurse educated clinical pharmacist and her family physician till we get this great result. The second case which is we done for him a renal denervation. He's a hypertensive, diagnosed 2 years back, smoker, pre-diabetic, HbA1c of 6%, overweight. He had grade 2 hypertensive retinopathy, and he had normal GFR with microalbuminuria. He was on combined amlodipine, valsartan, thiazide, spironolactone, and bisoprolol. This patient himself, he doesn't want to get a lot of medication. He said if there is any chance to decrease the burden of those medications. So he was referred to our clinic. Again, our nurse educator notes she get the home blood pressure technique was right, with average of 158, no diuretics, no diurnal variation in the blood pressure. So this is less likely to have another cause of his resistant hypertension. The weight management, they work with him to get out of 7 kg, but still blood pressure is not controlled. The clinical pharmacists indicate he had a medium adherence, tried to optimize the diuretic dose, but failed due to the side effect again. So, and the secondary cause was excluded as well. So this patient underwent, we put him in renal denervation. Our protocol, all the patients, they should get a CT scan. So we use the CT scan for many things. We found a lot of, especially ladies, they have very small arteries and less than 3 centimeters. So we exclude them from the beginning without exposing them to the procedure. And if there is a patient like with very anomal or very difficult, like we know this patient, he will not able to do more ablation cycles. So we exclude them from the beginning based on the CT data. So this patient was okay. So we get him a femoral access with GR for guide catheter. I use Grand Slam all the patients. This is our workhorse soil for the renal denervation. We give upfront of 200 nitrate and verapamil intraarterial before introducing, because it's for French a catheter. So it's better to have prepare the artery before that. The contrast are only 60 ml because we know we don't do much of injection because we have the CT data that help us in saving a lot of contrast. So this patient get a right kidney of 22 ablation and the left kidney of 12 ablation, and we close with the angioceal. So after 8 weeks follow-up, average blood pressure 129 over 78. And as you see the shading here, it is the nighttime. He get the dip in his blood pressure, which is really significant, especially in the registries and the RDN, the group, they have this. And as you know, based on the pool data before, this time it's losing of dip, and it's associated with high risk of cardiovascular and stroke incident. And he was only an amlodipine, valsartan, and HCT of 10 to 160, 12.5 as a combined tablet, and we get his control. So the key message from those cases, essential collaboration among cardiologists, internists, nurses, and family physician is crucial in such program. Clear pathway, enhanced patient selection and procedure outcome. CT imaging crucial for assessment of renal artery anatomy, I think. Ablation cycle, precision, and number critical for optimal outcome. Yes, we don't have a target, but I think more is better. Whenever like you have more cycles, the good outcome. Restored nighttime drip, improve the cardiovascular outcome and systemic benefit. I think this is one of the benefits of the RDN that we have noticed based on the available registry and data. Thanks.
Beautiful. Thank you so much, Dr. Al-Majid. That was really informative. And thank you for sharing your experience. I'm going to ask 2 questions. First question, the follow-up. You mentioned about that, Dr. Naif. Dr. Cohen, how do you do your follow-up?
For the renal denervation.
Yeah.
So what we do, we've set up like renal denervation clinics. So we see the patients generally about 4 weeks after the procedure, somewhere around that time. And then we try to see them like 3, 6, and 12 months. and then annually, because like they're going to go back to their primary care, primary provider, whoever that is. But what we do is we do get imaging somewhere between 6 and 12 months, because if you look at the data, there's almost no renal artery stenosis and vascular injury. But if it occurs, that's when it occurs. So I would say that's important. And the importance, well, the reason we see them that often the first year is, firstly, we want to collect the data. But secondly, safety issues, which are minimal, but also, you can be adjusting the medications. I wouldn't expect to just drop medications down, but over time, that's why it's important, is because, you see this incremental improvement.
My next question, we have issue here, for example, for the insurance coverage, for those who are non-compliant, they won't cover that. How do you do, and does Medicare or insurance company cover that in the US or no?
You mean to get renal denervation?
Yeah, for renal denervation. If patient is non-compliant, would that make him eligible for?
I mean, Ty can answer better than me because he knows all the finances. But truthfully, we're having a lot of issues with anybody, even the ideal candidate, getting renal denervation, because there's still some things being worked out. So it depends which kind of insurance they have. But they haven't actually specified, like they either cover it or they don't, but it doesn't seem to be the underlying cause. But I mean, if it's a national problem, it's worth going to the insurers, and making a case, because even if you drop a patient's blood pressure 10 millimeters systolic, over time, you're going to reduce their risk for heart attack, stroke, which is much cheaper in the long run. So that would be my suggestion.
Yeah, Waleed, I would have to agree with that statement, just because, even if looking at the guidelines that you guys have, technically uncontrolled hypertension is an indication for renal denervation in Saudi Arabia. So like it doesn't necessarily mean resistant hypertension for sure, but they also include uncontrolled hypertension as well. And so if they really are going to, nitpick to say, the patient must be compliant, that's technically not the definition of uncontrolled hypertension, which is within the guidelines that you guys have. And similarly, in the United States, we're making that same argument to say it's not necessarily just the resistant folks. Of course, those are who we studied, but uncontrolled hypertension folks have means to benefit here. And especially like what I talked about in my original talk, that if you look at the cost effectiveness analysis for single payer systems, like what's happening in Saudi Arabia, but certainly you have a mixed payer system as well there in Saudi Arabia as you do in the United States. I think it does make a cost effectiveness. It is cost effective to perform renal denervation regardless of the patient's compliance or not.
Excellent. Question for you, Ty, is Dr. Ariz Al-Ghathami asked about, when do you call the procedure successful?
So that's a tough question to answer. I think the only way that how do you define success in these cases? Intraprocedurally, there really is nothing that you can use to say we are now done with the procedure, right? There's no target to say, and this is something that I alluded to in one of my answers, is to say, there's one technology that's looking at stimulating while you're in the procedure to say, do you get a blood pressure response? If yes, then ablate here. If no, you can skip this portion. That technology is not really ready for prime time yet. I think the only way that we can define success is really 6 to 9 months out from the procedure to, whatever you want to call it, 6 months for a spiral, 2 months for ReCore, to say that you made a difference in their blood pressure, i.e. some of the stuff, the data banks that we have here in the United States, which are looking at procedurally based strategies, for registries, the procedure itself, there is no yes, no, you're done. And that's part of the problem with the data right now in the United States, is that we have a lot of procedural data banks to say this is what you did, but that's not how you measure success really for renal denervation. These are patients that you have to follow for 3 to 6 months. And so that's what Debbie's talking about, is that there are newer registries that are coming out. Obviously you guys are doing, it sounds like, a lot of spiral. So Global Simplicity Registry, really, really important to continue to give to that registry. But certainly for us in the United States, we're coming up with national ways of following these patients for longer than just the procedure itself.
And, remember the timelines in those studies, like, for example, I think SOLAR was 2 months, but those were very arbitrary. So it doesn't mean if you don't respond that you're not going to respond at 2 months. So I would give people time, like I would say at least a year before you can say, okay, that this person was a complete non-responder.
Thank you. Yes, go ahead, Dr. Ahmed. Hello?
Yeah, Dr. Faisal. So,
Yes.
Dr. Waleed, I have a question from the audience. What is the most common complication, at least that known or any one of us had in his experience during the procedure?
You want to answer that?
Yeah, go ahead.
I mean, the biggest one that I think that people get shot, like newer operators will be surprised about, is the amount of pain that's associated with the procedure. Not really a side effect per se, but you have to counsel your staff to say, you're really going to have to be pretty heavy-handed with your sedation. On the other hand, I mentioned this in one of my answers, is that when you take a look at the randomized control trial, specifically hypertension on, the PI for the trial specifically chose locations that were naive to utilizing the device. And so these are new operators, very similar to people that are starting off now. And even still, when you take a look at those safety events, they're all zeros for things like perforations and dissections and these sorts of things. You will see post denervation changes in the angiograms, but that doesn't necessarily mean that they're true complications. I think the only complications that we've had, honestly, are groin hematomas, things that come with femoral approaches, which I'm hoping that in the coming years that the radial approach, which is hopefully coming down the pipeline, is going to start to just take care of completely.
A question for Dr. Naif. There's a question about, is CT renals mandatory before RDN?
No, I don't think it is related to the RDN, because we are doing it as a part of the secondary screening for those patients to exclude renal artery stenosis. But it's for the RDN itself, I don't think it's mandatory for those patients.
So,
Dr. Wael, what's your
go ahead.
practice?
No, I don't do CT scan before because of the issue of the contrast in our community. Most of the patients, they are afraid. So what I do is the routine. It's a femoral approach using the right guide catheter, the renal guide catheter, which is a short catheter. I do an injection before that with a big tail to look for the renal artery, which level, if there is an accessory. This is a very important step. I saw some of my colleagues, they do selective injection immediately. I think the renal artery accessory is really, as mentioned earlier by all the colleagues, the origin is sometimes difficult to, it take an abnormal origin, either from far below or from far above. When I engage with the renal, I usually go contralateral of the artery I want to engage. Then I go ipsilateral for wiring. Sometimes I go caudal or cranial if there is overlap to separate the arteries, especially if there is difficulty in wiring. And then just introduce the ablation catheter. Before you ablate, you pull the guide wire. Don't ablate at the bifurcation. Ablate the branches, the first generation branches, then ablate the main artery. So this, I answered a couple of questions because some people, they'd like to know what is the steps. And I use Medtronic most of the time.
Excellent. Dr. Ahmed, do you do CT scan for the renals part of your practice?
No, actually, I don't. I don't use CT scan because same purpose. We're going to inject quick. So, to start with, this should be like multidisciplinary clinic and should be like run by non-intervention. My hospital, we have like specialized clinic for those patients run by family and medicine and nephrologist. And after excluding secondary cause, I make sure adherence for medication, and they send the patient to me. Then I saw in the clinic and evaluate of this procedure. So I never ask for CT scan beforehand unless I have to, because with the big injection, see that.
Excellent.
Dr.
Yeah. Ahmed,
question for the audience. What's the role of RDN for labile blood pressure patient?
Your voice is really not clear, Dr. Ahmed.
What's the role of RDN for labile blood pressure?
what is the role of RDN for labile blood pressure, for labile hypertension?
I mean, I can say that we've had some patients with significant, for example, chronic pain from, like we had this patient with chronic interstitial cystitis and her blood pressure was very high. And so she did very well actually with renal denervation because it was very sympathetically driven. So I won't say it will work for everyone, but you know, depending on the underlying reason, it could be very effective.
Excellent. Dr. Cohen, what's your practice? Do you do CT scan prior to?
So, I mean,
RD?
we're going to do CT or renal Doppler, you know, as part of our evaluation for secondary hypertension. So I don't think you need to do it actually for the renal denervation, but you don't want to go on the table and find out they have a, you know, tight stenosis and you can't do it. So I think they need some kind of vascular imaging in the workup before they go for renal denervation.
Ty?
Yeah, I don't think that it's absolutely necessary either. Remember that these patients that were included into trial were those that had preserved EGFRs as well. So they had the ability to you know, accept the contrast volume of a CT scan prior to. But I have to agree with Debbie that it is nice to have a lay of the land of knowing exactly how many accessory renal arteries there are and how to plan this out. On the other hand, that's not the primary reason of what we're getting the CT scan for. It's really to rule out FMD and renal artery stenosis. So it's not absolutely necessary, and there are other ways to gain that information. But on the other hand, it would be nice if you could get it if possible.
Yeah, we in our institution we have the secondary hypertension workup protocol. We do an MRI with a cardiac, aorta, look at the quark, looking at the heart. At the same time, we look at the renal parenchyma, adrenals, renal arteries, all the way, and looking at the FMD at the same time. With the gadolinium, it has pretty good resolution for that. Dr. Faisal Al Nasser and Dr. Ahmed Al Hamami, do you do CT scan? The reason I'm asking everyone because it's really, I think what Dr. Naif doing is really good that rather than going blind, you have an idea what you're gonna go through. It might change my practice.
Assalamu alaikum. I will tell you something. The procedure is simple. I don't do CT scan for my cases, but if you have the capability, try to do a rotational angiogram instead of the aortic angiogram. It will give you different perspective. It will tell you can manipulate at the workstation and look at different angles and so on. It is something, if you have the capability, try it in one or two of your cases. You might get something interesting. It will tell you about the accessories, about the access, the location. You will get some more information. And it doesn't consume a lot of contrast. Usually it is diluted 50 and 50, and it is a 5-second run. You will get images similar to the CT angiogram.
Excellent. Then I think we have to conclude here. We passed the
Waleed,
time.
if you allow me, just a quick survey on the chat. There is an important comment that, by Dr. Debbie. 80% of the patient respond to RDN at 3 year. Reduction is around 20 millimeter mercury, systolic, diastolic, and we saw also a good case that the DIB is improved. 20% they are not responding, so you have to be patient. Yes, the number of medication will decrease with time. The only available in the market now with a lot of robust data is the Simplicity by Medtronic. And I think like this, we covered most of the final word, Waleed, before I conclude with you.
Thank you very much. That was really informative. So in summary, really, I thank all the presenters are really outstanding. The discussion was very fruitful. I've learned a lot from each of you. And for the audience, select well, plan well, and have your expectation with your patient before you start the procedure.
Well, with that, also, I would like to thank all the attendee and all the speakers. Thank you very much, all of you. SASIS, the Saudi Arabian Cardiac Intervention Society, the leading society in the region, is very proud and happy to have this participation with SKY. Thank you very much, Medtronic, for the generous support. And we wish you all the best, and see you soon in another webinar.
Mhm.
Thank you. Well, thank you.
Thank you.
Thank you. Thank you very much.